The purpose of the Malcolm Peterson Honor Lecture is to foster consideration of broad and significant themes that relate to the highest ideals of medicine and the many ways in which physicians can serve. Throughout his career, Dr. Peterson exemplified aspects of such service as an investigator, educator, and clinician, as well as through his extensive community service and deep commitment to social and public issues affecting the health of all persons. It's very fitting that one of Dr. Peterson's former colleagues would give today's Peterson Honor Lecture, and I'm delighted to introduce Dr. Mark Smith as our speaker. Mark was the founding president of the California Healthcare Foundation, which he led since founding it in 1996 until 2013. Mark helped build the foundation into a recognized leader in delivery system innovation, public reporting of care quality, and applications of new technology in health care. Before that, Mark was the executive vice president of the Henry Kaiser Family Foundation, where he oversaw programs in HIV, reproductive health, and the healthcare marketplace. And going back even before that, he was on the faculty at Johns Hopkins and directed the AIDS clinic there. Mark was elected a member of the Institute of Medicine in 2001, and very notably, he chaired the IOM's Committee on the Learning Healthcare System, which produced the widely publicized report, Best Care at Lower Cost. A board-certified internist, he's professor of clinical medicine at the University of California at San Francisco, and he maintains an active practice in HIV care at San Francisco General Hospital. Please give a hearty welcome to our honored lecturer.
Thank you very much, Eric. Good morning. Good morning. Buenos días. Voy a hacer mi discurso corto hoy en inglés porque aunque estamos en la ciudad de San Diego, tenemos aquí mucha gente que no hablan español, que hablan únicamente inglés, entonces disculpe mucho. Me explico. So, it's a pleasure to be here and an honor. My wife says that you should never call anybody an old friend, so I will say that it's a pleasure to see so many friends of long standing here. I've been a member of the SGIM for a long time, though it's been a long time since I've been to a meeting. An old teacher of mine said that when you're talking to a group of people, you should tell them what you're going to tell them, and then you tell them what you told them. So this is the part where I tell you what I'm going to tell you. I'm going to make a couple of observations about this meeting and reflect a little on the relationship between SGIM and primary care. You'll note the title of my talk is Primary Care, Romance and Reality. I'm going to say a little bit about the romantic period of primary care, of which I am a product. Say a little bit about what I think will affect the future of primary care, what has changed it over the last 30 years of my career. And then I'm not smart enough to know what the future holds, but I am going to say something about the few things that I think I'm sure about in terms of how primary care will evolve. And along the way, I'll try to illustrate that with a few stories from my own life. I should say here I'm going to address most of my remarks to the young people in the room, and in this context, young, I mean 40, 45 maybe, because you are the future of our field, you're the future of the profession, and not coincidentally, you're probably the only people in the room who are not so tied to the past that you're not beyond redemption. So it really is to you that I mainly speak. So two things strike me about this meeting. First is how big it is. There are a lot of y'all here. And how broad and deep and heterogeneous the topics covered and the studies reported. And it's evident not only that SGIM is thriving as an organization, but that the field of academic generalism is, at least in some ways, thriving. The second thing that strikes me is a little depressing, because as I read the list of awardees, I realized that not only do I know a lot of the people being given Lifetime Achievement Awards, like Marty Shapiro and Eliseo Perez-Stavo, I know the people who are on the selection committee, like Tom Inouye and Marshall Chin and Preston Reynolds, but the scariest thing is I know the people that the awards were named after. So Elnora Rhodes and John Eisenberg and Herbert Nickens. And so for you young people, I want you to know these were real men and women that were alive and around and active in my lifetime. This is not like Daniel Webster or Agamemnon or something. And you should know that because this field was founded by pioneers. This field was founded by people like John Eisenberg and Bob Brooke and Hal Sachs and Steve Schroeder and Bob and Suzanne Fletcher and Tom Del Banco and others. And when they founded this field and this organization, it was fairly hostile terrain in academic medicine. It was fighting against the subspecialists. It was fighting about the ethos that generalism was not sufficiently academic or investigative to deserve a division, let alone to lead these departments. And the reason I'd say that to you young people is that some of the changes that will be necessary in medicine and in academic medicine will take similar leadership and creativity and courage from you. Because some of you are now trudging the now well-worn path that was blazed by those pioneers. And some of you will need to step off that path and get out of the R01s and the promotions and the grants and the papers to do some things that require a little bit of chutzpah to initiate some of the changes that we need in academic medicine, as those men and women whose names I just read off did in founding this organization. Now, how many of you know that the original name of this organization was not the Society for General Internal Medicine? There you go. It was the Society for Research and Education in Primary Care. And it's worth noting that it no longer is. So primary care has always been part of the DNA of this organization, is to this day, but it's apparent to me as never before that primary care and generalism are overlapping but not synonymous. There are probably some hospitalists in the room. Probably you along the back, you're ready to go intubate somebody if necessary. But that's just one of several examples of how this notion that started this organization of the unity of generalism and primary care has actually gotten drawn apart over the years under the influence of the progress of science and the progress of changes in the system, despite our ideology, despite the kind of romanticism that was imbued in some of us who trained during that period. Anybody know what the Declaration of Alma Ata was? All right, so the International Conference on Primary Health Care in Alma Ata, what was then the USSR, now the Republic of Kazakhstan, in the same year that this organization was born, with that now famous statement that health is, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Anybody got there yet? Anybody? No, me neither. But the Alma Ata conference and that statement was an important part of kind of the worldwide surge in primary care at that period. It was a reaction in many ways to the technological emphasis of Western medicine. It was directed at the developing world, but it had its echo in the United States, in which I believe the impulse was largely against the over-specialization, increasing fragmentation, and relying on technical solutions in the United States, and found its reflection in the birth of Strepsim. Now here I have to give a hat tip to the Robert Wood Johnson Foundation, without which you all would not have jobs. Because the Robert Wood Johnson Foundation, in its ultimate wisdom, not only helped seed this field by creating the Clinical Scholars Program, whose early leaders became the first successful generalists and then division chiefs of general medicine and general pediatrics, but also helped form the organizations that gave those early generalists an institutional home, a place to get peer support during those early difficult times, an organ in which they could publish so that they could get promoted. So the Johnson Foundation actually played a key role in developing not just this organization, but this entire field. But in my view, there was a bit of romanticism early on in the way in which we saw, at least those of us who studied at the feet of those men and women, primary care. I won't give you definitions, I'll give you my interpretation of what we meant and still mean by primary care. First contact, care for common routine conditions, care for the whole person as opposed to an organ, the coordination of the many specialists and other providers in the system, and a generalist as opposed to organ-based perspective on the wisdom or appropriateness of various procedures, diagnostic or therapeutic. But my view was that the early notion of primary care was flawed, at least in some ways. First, because it was very physician-centric in a way that we now have come to understand limits our capacity to provide services that patients need. It was a bit ubiquitous. My recollection was that we were going to take care of patients in the hospital, at home. We were going to know the things they were exposed to at work. We were going to screen them for mental illness and social disease. We were going to make sure that the rugs in their home didn't slip so they wouldn't fall. We were going to know their family dynamics and their religious and cultural history. We were going to know all these things everywhere. We were going to be omniscient because we were going to know everything about every possible organ system and disease that our non-differentiated patients were going to have. And we were going to be omnipotent because we were going to coordinate everybody else in the system. In 1985, John Eisenberg wrote an article called Gatekeeping, a New Role for General Internists, in the New England Journal. You will see as a theme that the New England Journal generally recognizes reality about 5 years after it's happened. And so John was at that time describing a phenomenon that was actually already well underway in the actual real world of actual real doctors and real patients out away from our academic medical centers, much as a decade later Bob Wachter was describing hospitalism, something that had been happening for about 5 years. But that was a harbinger of things to come because in many ways the role of primary care as gatekeeper began increasingly to be taken up in policy circles as this Uber coordinator, and those of us who lived through the backlash of the managed care backlash recognize what happened to that. Given the enormous development of biomedical science, it's become increasingly difficult for any individual to retain or know, let alone regurgitate on command everything that they need to know. My own experience is something like that. I am a card-carrying, dues-paying general internist, but basically an AIDS doc. And 12 years ago, if I had a patient with HIV, as all my patients do, and slightly elevated blood pressure, just between us, I wasn't really all that worried about their blood pressure. Because that was like the least of their worries, right? And you'll recall that 12 years ago, if they were doing well, they were on probably 3 medicines, 2 of these twice a day, 3 of those 4 times a day. Those go in the refrigerator. Those get taken with meals. These you can't take with grapefruit juice. Oh, my God. So increasingly, I have to go back to being a general internist. And I'll tell you a story at the end about a patient of mine who is kind of living proof of how difficult this work is. But the romantic period of primary care kind of came to an end in the 1990s. I can describe, however, its crescendo because I was a member of the Clinton Healthcare Reform Task Force at a time when primary care was all the rage in policy circles, and I was deployed one day from the old executive office building to go meet a representative from the American Academy of Dermatology who was there to make sure that they got included in whatever was going to go on. And not knowing who was in the room, he didn't know who I was. We were just some drones deployed by the Reform Task Force. He introduced himself as the head of the American Academy of Dermatology and described dermatologists as primary care providers for the skin. Which, of course, prompted the question, does that mean that nephrologists are primary care providers for the kidney? So, with the end of the romantic period of primary care, it's worth thinking about how primary care has evolved in ways that are perhaps different from the way the pioneers and those of us who grew up in the romantic period thought it might, and what influenced that evolution. And I think there are four main things. The first is the changes in organization and financing in healthcare, and my poster child for this is hospitalism. When I was growing up, as a primary care romantic, it was assumed that one took care of one's hospitalized patients. So what happened? Well, we institutionalized patients less and less frequently. They're there for shorter and shorter periods of time with more and more intense things going on that have to happen at a quicker and quicker pace. Oh, and by the way, the ergonomics of the average outpatient primary care doc, in which if you had 3 or 4 patients in the hospital at any given time, it might make sense for you to make rounds on your patients in the hospital, no longer made sense because you now might have a patient in the hospital every 2 or 3 weeks. And it made no economic or logistical sense for you to devote part of the day to doing that, particularly when that hospitalized patient had to have 18 things done by noon. And so the ideology of ubiquity in primary care began to crumble as hospitalism took over. Not because of the ideology, despite complaints about the lack of continuity, and despite some real concerns by both patients and doctors at the time about whether or not this was actually comprehensive. My view is that the days of primary care providers providing most hospital care are gone, and probably good riddance. I gave a talk at the first hospitalism conference that Bob Wachter organized, and I said the reasons that people went into to hospital care were, as usual, and as in most of life, related to the 3 things that power most of our activities in life, namely power, money, and sex. And the power and money part are clear, but the sex part is this. If you're a general internist and you spend most of your day advising Mrs. Williams to change her naproxen dose, there's nothing sexy about that. But anytime an internist gets to say stat, that's sexy. So the reality is that for many of us who'd spent 3 years learning how to float Swan-Ganz catheters, and then were being condemned to a life of changing Mrs. Williams' naproxen dose, the note that you could continue to float Swan-Ganz catheters and look for cardiac tamponade for the rest of your life and get paid for it was just inescapably delicious. The second thing that has affected primary care is the change in the biomedical knowledge. We have far more knowledge to deploy and to use for our patients than we used to, and it is, in my view, increasingly attractive for people, notwithstanding the influence of the financial impediments, to limit the amount of knowledge for which they're responsible. It is, I think, an underappreciated reason for people specializing. The third is the changes in IT and computing capacity. How many of you flew here to San Diego? How many of you saw a travel agent to make your travel arrangements? How many of you have cash in your wallets or purses? How many of you saw a teller to get your cash? So if you think about it, really, healthcare is the only service industry that hasn't been fundamentally transformed by information technology in the last 3 years. I tell medical students every year, when I was your age, if you wanted to have a big weekend, you had to go to a place called a bank before 3 o'clock in the afternoon. They look at me like I'm insane. And the fourth thing is changes in our patients. It's amazing to me that we still talk about how we should be deployed, what our scope of work should be, how our practice should be arranged, as if it's up to us. We are really the only service industry that has a waiting room. Can you imagine any other service industry that puts a headline outside its quarters that says, "Attention, our time is more important to us than your time"? So some of the changes that we are seeing and will see, I think, even more profoundly in the next 20 years, have little to do with what we think should happen, and will have more and more to do with what our patients think should happen, no matter what we think. I'm reminded of the early days of managed care in California when I had friends who said, "My patients love me. They would never change providers for $50 a month." Wrong. So, what are the things I'm sure of? I'm not sure of much, but I'm sure of this. First, the future of primary care is in organization. It is not onesies and twosies. It is not isolated docs. Now, that doesn't necessarily mean joining an 800-person medical group, because the advent of modern IT means that we can now create virtual groups, groups that have some of the capacity of data exchange, peer review, decision support that you used to have to be a member of Permanente to get. But it is clearly not going to be the province of individual providers. Second, people will be paid in part on the basis of triple aim metrics. That is to say, better health. What outcomes do your patients get? Blood pressure, blood sugar, hemoglobin A1C, FEV1. Better cost per patient, mainly reducing hospitalizations in ER and certain procedures, and better patient experience, which will be measured by retention and by surveys. Third, the core skill of primary care will increasingly be not in the domain of physical examination and differential diagnosis, but in teamwork and management. And fourth, I believe there'll be a decline in the importance of many of the things that we've held dear, particularly as generalists, which is our ability to do differential diagnosis and manipulate a stethoscope to hear an S3. Would you like to have your car go over a bridge built by an engineer who used a slide rule? Well, I know engineers used to use slide rules and doctors used to use stethoscopes. But increasingly, many of the things that we have held dear will be taken away by technology, and we'll need to adjust what our definition is of what physicians do. So I want to end with this note. I want to end with a note of optimism, because I've been a little bit pessimistic and maybe even sarcastic about our romantic notions of primary care, but I am not pessimistic at all. I'm actually of the mind that the capacity of our American healthcare system to churn out biomedical knowledge is hamstrung mainly by our inability to have figured out so far how to choose, train, pay, deploy, and refresh the human workforce that's necessary to deliver the miracles of which our system is actually capable. And I'm confident that some of the enthusiasm that I see here among those of you under 45 about the future of the field can help make that possible. I saw a patient 2 weeks ago. I've been seeing him for about 10 years now. He's 71 years old with HIV, just got his hip replaced successfully, walks his grandchildren to school. He's on one pill once a day for his HIV. Hell, I take more medicine than he takes. It's a miracle. It really is a miracle. For those of you who are old enough to have lived through that Holocaust that was beginning when this organization began, it is nothing short of a miracle. So for those of you who are under 40, 45, You have the capacity to push this field forward into the next part of this century to deliver those miracles to everybody we see. Thank you very much.